Services Plan Board Workshop for July 2025. Dr. Shanoff, would you like to start us off?
Thank you, Madam Chair. Good morning, everybody. It's that time of year again when we talk about the healthcare and providing a healthcare update to the board. As we know, this is what I would call one of the anchor benefits for our district. This is something that is unique. It's a model that's unique and has worked and benefited our district tremendously thus far. And so we want to provide the board an update on where we are at the end of this particular plan year, and then how things are looking going into the next plan year. So I'm going to go ahead and turn it over to Ms. Graber, and she can introduce the team.
Get her a mic. I think she could go up to the podium, maybe.
Good morning. My back towards everybody. All right, here with us today we have our advisory team. We're still waiting on one more, but we have Barry, one of our advisors, Ashley Baco with Rosinger, Carolyn Grant also, and then Jay Miniotti is our actuary. We also have Kenneth Aldridge here, and Ms. Dreeslemick will be with us shortly. So, making her grand appearance right now. So. The team has worked with us for several years now, so we really have a good cohesive team that understands the intent of our overall program. And so the purpose of the workshop today is really to give you all and our employees and the public an update on where we are with our overall health insurance plan, including the financial situation that we're finding ourselves in. So I'm going to turn it over. I think, Carolyn, are you starting, or Ashley?
Thank you, Sarah and Dr. Graber. As we get started, we want to give you a little bit of history of where we have been in the growth of our plan. On slide 3, you'll see the difference between our plan and the traditional healthcare model that we had before starting our new plan that we have. So where the focus was on the traditional model is there's no transparency, no incentives for members to go to certain providers, there's no advocacy in prescription drugs. We have things like spread pricing, no control of your formulary. And then under our model, you'll see the things that have been integrated and incorporated in our plan with active management. Things like we focus on quality, we do incentives for members to use doctors that have been tested as being quality doctors. We eliminated spread pricing on the prescription drugs. We control the formulary, not only for the members' benefit, but also for the plan's benefit in moving things around as things go generic and things like that. And we focus on eliminating and reducing member costs. Our plan is self-funded. You often hear the word self-funded, self-insured, partially self-funded, partially self-insured. Those all really mean the same thing. What that means is the school district is responsible for a certain level of risk and dollar amount for each member on the plan, and after a certain amount, then there is reinsurance, or called stop-loss insurance, to cover that amount over that limit. So on this illustration, you'll see here, we have an individual stop loss for each member on our plan of $1.5 million. So it means we cover that first $1.5 million for any member's claim. Then after that, we have called an aggregating deductible, which is a deductible for the whole group. They have to make an extra $135,000 like little corridor, a little buffer there. And after that aggregating deductible, then the reinsurance then starts. So that's on how our plan works right now. We have analyzed over the years of lowering that amount for the stop loss to kick in sooner. And each time we look at it, it has been advantageous to keep our amounts at their limits that they are right now. But again, we look at that each time because with our claim amounts, we want to make sure that if we can get reimbursed for some of those claims, we want to. But of course, the cost increases when you lower your deductible amounts. When we focus on quality, here's a kind of a good example of why we want to focus on that. Is, for example, we want to incentivize doctors and hospitals and other facilities for the members to go somewhere where it has good quality scores. That means they have good outcomes, they have less complication rates, good readmission rates, they have, med malpractice, things like that. So we want to make sure that we recommend those providers for people, because what we find out is those providers that have good quality actually end up costing the plan less. So in other words, in your life, when you buy something of a better quality, whether you buy a new television or a new car, you buy a higher or luxury car, you expect it to cost more money. In the world of healthcare, the better quality providers charge less money to the plan.
But,
So
but
it's
we
something-
also give them choice.
Yeah.
If they choose to go to that doctor that they've been going to for a long time, even though the quality's not great, they have the choice.
Yeah, members always have a choice. So we put a carrot, it's an incentive for them. If they use the recommended providers, then their deductible is waived for the plan. So again, what a low-quality provider would look like there. And why transparency? We want to make sure that the school district is getting the best net cost for every aspect of their plan. So we want to get under the covers, that nothing's hidden. We want to make sure that you have the best, again, for all the providers, best quality and best at a fair cost for all aspects of our plan. We control the formulary. So which drugs are, if we know that certain drug is having a generic or a biosimilar is coming out, that we're able to move the formulary accordingly so we're getting the best recommended cost for the plan and for the member. We're expansion of sourcing for our drugs. So things like we're doing international sourcing. We're working right now with J-codes. We're moving drugs that are under the medical plan right now, so infusions that are done for members at infusion centers or at the doctor's office. We're working with the pharmacy plan to move them over because what we're finding is for the majority of the time, the cost is less under the pharmacy program than under the medical program. And additionally, if there are any rebates, we're able to get the rebates under the pharmacy program, not under the medical plan. So we're working on those on a case-by-case basis and moving those medical claims to the prescription drug program.
Can I ask a question there?
And what this means is,
She's asking.
oh,
Can I ask a question with
Sure.
that? For those types of healthcare issues, the way they're serviced is still the same, though? Their cost is just being run through the pharmacy side versus?
great question. So on a J-code, so if a member's getting an infusion either at the doctor's office or at an infusion center, generally they have to go to that facility. We're able to work it out that the member can actually go to another place like that or even have it at their home.
Okay.
So of course we want to make it so it's a better member experience, but also a lower cost for them and for the plan.
Okay, thank you.
Gives them convenience at that lower
Yeah,
cost.
for sure.
Correct.
Thank you.
And the impact has been when we make lower barriers to care and better access to care for the members, we find that the overall health will improve. People are compliant with their medications. They go to the doctor when they need to versus that person waiting. They have bronchitis, then it becomes pneumonia. So that's how we have designed the plan. And that ultimately lead for better savings for the plan, better savings for the overall, for the employees as well. And of course, reducing the costs gives us more access to implement more programs for the overall plan as well. 2 years ago, we introduced the new health center plan. So in the past, we had two plans, the Essentials plan and the Advantage plan. And both of them were open access. Members could use the plan as they deemed necessary. The health center plan is more of a medical home model, where the health center is their medical home, and if they need to go see any specialist, they would need to get a referral from the health center provider for referral to that specialist. The advantage for this plan for the members was an extremely reduced cost reduction as far as the payroll goes, and And we had people already using the health center like that, so we had a great open enrollment, and it continues to be a very popular plan for the members. There are also better benefits on this plan. There are lower co-pays, there are lower deductibles, lower out-of-pocket maximums, and because everything is being controlled or administered by the health center. There are situations where the members do not need referrals. So those are, for ladies, your OBGYN visits, mental health, urgent care. If any children are on the plan, they don't need a referral to their pediatrician, convenient care, or emergency rooms. Members can still access all of those without having a referral from their primary care doctor. So under this plan, it's really modeled after the Rosen Hotels and Resorts plan. We're famous for our plan. We have a medical home at our on-site medical center as well. So this is very normal for us, and so guiding the school district into this model was very natural
yeah.
for the progression with that. And what we found out after the first year, and as we're tracking it, is that the cost for the overall members that are in the health center plan are lower than the other two plans, but those members that are there have increased mortality or risk scores. So they have more conditions, they have things that have to be managed, but that's a great place for them to be managed. So if there's somebody that has diabetes, they have, COPD or anything like that, for them to be watched over at the medical home of the health center is a very great environment for them. And on slide 8 is all the different reducing barriers to care that have been implemented over the years. I know that slide is very, very busy, and it's a lot of green on there. So things about like the deductible incentive, for example. If the members use the recommended providers that are based on quality and outcomes, then they have their deductible waived. That's something that was implemented for the plan. The nurse concierge. So again, so they can call the nurse and speak to them about any type of medical issues they have, get a second opinion if they would like to on that. The no-cost imaging. Our relationship with Green Imaging has been tremendously successful. Members engaging with Green Imaging pay no cost for their imaging, whether it be something as simple as a simple x-ray, or it be a mammogram, or a CT scan, MRI. Because the cost at the Green Imaging contract is so much less, the members get it free and the plan benefits from that. And anything that we can bring on site is a great solution, so then the members don't have to go further and take more time off work to access that care. So we've had the mobile dermatology, the mobile mammogram, and we're looking at the mobile eye exam being brought locally to the different locations so members can access care much easier than having to go outside with that. And we've had tremendous results with that. And one of the biggest thing is the on-site pharmacy. We're so proud of the on-site pharmacy that's there at the medical center, and that's getting tremendous results. And Eric Larson is such a great partner with the school district in maintaining that for us. So when members use that facility and access their prescription drugs there, they also get that at a reduced cost as well. So great integration there.
I think it's important to notice that historically, your health center had a dispensary. Mm-hmm. And this is a full-blown retail pharmacy. So increasing the impact for both the plan and the members.
In the health center engagement, now when we have the members that elect the health center plan, it's very easy for us to track that in the data. It's important to note that we also have members that are enrolled in the other plans, the essential plans and the advantage plan, that also use the health center. And they may use it, we put 3 different levels here. They might use it maybe just for the pharmacy or just for imaging. Some may use it on occasion if they're not feeling well and they're at work one day and they want to go to the health center. Or they might be all in and use it for everything. So it's important for us to recognize it's not only the people that have elected the health center plan, but we also have members on the other 2 plans that are also using the health center for their care as well. So Jay Midiani is here he's our actuary engaged with the South Senate, with the SDOC's plan, and he's going to go over a lot of how he tracks and works with the school district on the financials for the plan.
All right. Good morning, everybody. Thank you for having us in today. My bio is on 11. We can probably skip right through that. The actuarial analysis is on slide number 12. My role here is to serve in anything that is financial as it relates to the plan. So we will monitor and look at data over the course of time, try to make conclusions, try to dig into the drivers of cost as they relate to the plan. The measurement leads to evaluation. What is working, what is not working, what is a pressure point, where are there opportunities? From time to time, we will update our information, usually quarterly, but it can be, when we get to the renewal process like we're in right now, monthly. And that's what's going on now, where I'm working hand in hand with Sarah and her team to make forecasts about where not only do we think we're going to end up, but where are we headed in the next couple of years. The plan runs on an October to September year, but the fiscal year runs July to June. The fiscal year just completed. We have reporting that we do to the state, and our financials and the cash flows and all of those sorts of things are measured very, very finely at June 30th and then again at September 30th. From those forecasts, we will make recommendations, whether they are for pricing to the employees, plan design, and of course to you all as well. You all contribute a very generous contribution on a per pay basis that funds the lion's share of the cost of the plan. But our recommendations are worked through with the team, your team locally, to figure out what the best way forward is for the plan. Questions on any of that? Okay. On page 13, we're going to start to dig into some of the numbers, and those are going to take up a lot of the next handful of pages. So please stop me at any time if you have a question about what something means. If there's an acronym or an abbreviation here that you don't know or not familiar with, please stop me. I'll try to explain them as I go along. One of the main measurements that we will make is the trend of the plan. Another way of saying this is the inflation rate, the cost on a per employee per member basis over the course of time, PEPMs, per employee per member. This is the medical and pharmacy cost boiled into a particular number. It is inclusive of the claims of the employees, their dependents, spouses, all rolled up into this number. All right, so for a bit of a reference point, for the most recently completed fiscal year, July to June, the per employee per month cost was $785. All right, that does not include the health clinic. It does not include any of the administrative or stop-loss costs that are associated with the plan. It is simply the claim run rate that we have experienced here in the last year. You'll notice when you see the next column that it's up 16% over the prior year. What I like about this table is that it shows from a long period of time that over the long run, the trend in the plan has been in the mid-single digits, if not negative. Negative is obviously, in this context, a very good thing. There's been a lot of hard work and heavy lifting done over the course of the years, moving from a more traditional plan into your current, I don't want to say unstructured, but kind of an unbundled type solution as you have it right now. But we're going to dig into why is that up 16% year over year. All right?
Jay, if I could interject, first of all, Jay does not work for us. He's independent, and we think that's very important because we don't want his advice to be self-serving or biased. Secondly, you consult with other school districts.
You all are among the 8 school districts that I do work for throughout the state. They range from the Panhandle down south. So I get to see a lot of different things. Those school districts range in size. Some of them have 600 employees. Some of them have 8,000 employees. So over the course of that spectrum, I will see quite a bit.
In your experience, how does our trending over the last 6 or 7 years compare to your experience with the other school districts?
Out of the 8 that I know about, there's only one that has had more flat trend, but it's a much, much smaller system. They only have 600 employees on that plan. But in general, comparative to the other 6, you all are lower than that, better than that.
Okay.
In spite of having better access, better benefits?
All right. What is contributing to not only the plus 16 that we're going to talk about, but to the flat and lower and the negatives that we've seen over the course of time is on slide 14. And I'm going to take my time to kind of walk you through what this exhibit is. It's colorful, but it does have some detail in it that I want to draw your attention to. On the far left-hand side, those numbers in blue that are October 17 through September of 20, that is the large claim experience that you had under a traditional plan, where what I like to look at is the incidence of your large claims. And for this context, what is considered a large claimant is anybody who has cost the plan $100,000 or more. All right? Those are serious conditions. They're not necessarily catastrophic, but they are certainly serious to the employees, their families, and all that. We don't take them very, very lightly at all. That 3-year average was 89. So you had 89 claimants on average that rang up claims of $100,000 or more. The green section and the blue section, they are 2 ways of looking at roughly the last same 4 years. The green is on a fiscal year basis. That is important for today's conversation. We look at things on a plan year basis. The fiscal year helps guide on the numbers. The plan information helps guide on plan design and employee contributions and the like. But you'll notice that coincidentally, over the last 4 years, in each of those sections, we've averaged only 62 claims in excess of $100,000. All right, so there's been vast improvement. We were down 30% in terms of incidents, and this is the number of times we're ringing the bell at 100. The claim could be $101,000, or it could be $1.5 million. If it's over that threshold, it shows up in this table. Okay?
I have a question.
Yes, ma'am.
What would be an example of a large claim? Like
A
just
transplant,
roundabout,
for
like-
example,
okay.
or a NICU claimant, somebody, a child that was in the intensive care unit.
17 of our current high-cost claimants above 200,000 are cancers.
Okay.
Yeah, we're going to make a comment about cancer in a minute, but a cardiac event, end-stage renal, those types of things cost several hundreds of thousands of dollars. All right.
And then this number that's 89, is that our employees or is that like their dependents?
It could be either one.
Okay. Okay.
It's how many times we had one, and it could be for a child, it could be a spouse, it could be an employee.
We have a dependent right now with hemophilia, and that right now, for this plan year, they're approaching $350,000.
And Paula, if you ever wanted to find out, you know, how many are dependents and how many are employees, we do have the data and can find that.
Okay.
And we look at new hires, we look at terminated hires. We dice it up pretty good to do the best we can to get on top of it.
The bad news out of this slide is in the far right-hand column. In this most recently completed fiscal year, we've had 102 claimants at 100,000 and above. A dramatic increase. It's what contributes to that 16%.
Do we know if, out of this number, any of them were new to the plan? I know that you just said that you slice it up based on new, terminated. Do we know if do you have that data that you'll
I don't
speak
have
on?
it on me, no. We
Okay.
can find that out. Tenure
Make
with
that
the
a
plan,
takeaway.
if that's your question?
Yeah.
Yes, we can find that out.
I was wondering, for that 102, is that things that maybe happened at a school, or do you see like a trend, like they're all coming from one place, or these were accidents at a school, or like,
Well, to Barry's point earlier, half of them are cancers.
okay,
Usually, the incidence of cancer as it relates to these numbers is about 1/3.
yes.
All right, and then within the 1/3, about 40% of them happen to be breast cancers, which is not uncommon. You have a high female population. It's about 68% of your enrollees are female. So we don't find that to be the surprise.
Okay.
But we do find that cancers are up and constitute half of what's going on this year, as opposed to about 1/3 of what's usually going on.
Okay.
Are there ways that you're able to look at what other insurance providers are having across their?
Oh, that would be interesting.
You know, like, are they seeing the same trends with
We've-
cancer being
we've-
up?
We have some benchmarking information here.
Okay.
It's related to K through 12, and we will be able to talk about that. It's not specific to cancer, but it's certainly specific to inpatient, outpatient uses of pharmaceuticals, usage of the office visits and specialties.
Okay.
Any other questions on this? But certainly, if I was going to say what is contributing to this 16%, one incident of it here is these large claimants, the number of large claimants specifically in this past year. We're now on slide 15. And it's important, I think, for everybody to kind of understand, this is an $80 million annual expense plan, where about $65 million of that 80 is claims. All right, the rest of it is a fairly efficient way of running the plan for stop loss and admin, and a big chunk of it is the health center. All right, so when we look at non-health center, non-administrative expenses, the run rate of claims per month has steadily increased, but more than steadily changed in the last year. All right, this idea of going from 4.9 million up to 5.4 million, that extra $500,000 a month is $6 million a year, which is a little bit of a pressure point as far as budget. It's also the case that you've started and begun to cover more people. We covered 6,600 people overall, but we're now close to about 7,000 people, employees on plan and their dependents. All in, it's about 12,000 belly buttons, as we might refer to them.
Another question kind of going back, I mean, I think it goes across both, but is there a way to see too, like, usage rate of employees of their healthcare plan during this time or these last, the 4-year increment versus now? Like, are people using the plan more, and that's why also we're seeing the increase in claims and
We're governed by
high-level
HIPAA
claims?
guidelines, and so we can't be specific about certain people, but
Right.
we can, because we have protected information, we can look at things and say, well, this member used to not use the plan very much. Now we see that their incidence has gone up. I believe that is something that we can identify.
And in aggregate, keeping in mind that a significant part of our mission is to lower barriers to care, to get people to have screenings.
Right.
That's going to have a pricing pressure on the plan.
Exactly.
But it's better for the overall health of the plan and certainly the members. And catching these chronic conditions or major issues early keeps us from having to spend a lot of money later.
That's kind of where my question
Yeah,
comes
so it's a
from.
blended
As
investment.
people are being educated,
No question
or
about it.
more is coming
Yes.
across their, inbox to say, "Oh, let me go do this," when they maybe hadn't before, and
Right.
utilized it as much.
We view that as a good thing, but there's a cost for it.
Exactly.
And utilizing like an office visit co-pays, that's all nickel and dime things,
Right.
and that's very expected for the plan. The things that are unexpected is when we have one of these large claimants.
Right.
Now, when you're doing a lot of preventive care outreach, have your mammogram done, have your colonoscopy done, all of those things, have your skin, your skin checked for skin cancer. And those are all, not expensive tests, but the results
Could be
may
expensive.
yeah.
But driving, to your point, Heather, driving someone to get that screening, okay, that unfortunately is, if it doesn't if it doesn't prevent it, unfortunately, they discover something, okay? So it might end up being a $100,001 claim versus a 1.5 million claim because we're driving them there.
We're generally for preventive care, screenings, and all that sort of thing. We don't want that, Carolyn talked about barriers. We're eliminating those barriers. We don't want people to not take advantage of these things, be they administered in the health center or at their own physician of choice. All right. Slide 16 is the prelude to a deep dive into the numbers. We've talked about the incidence of large claimants. The other culprit towards today's financials is the pharmacy spend. Your group gets a lot of prescriptions. Some of them are at very, very low cost, and there's something that is to be said for that in a positive way. But when we get to the benchmarking of things, it's much higher than average that we would see in other groups.
I know that with our pharmacy strategy, we were sourcing specifically specialty prescriptions from several different places. Are we still employing that strategy?
Yes, so we monitor especially the specialty pharmacy with a laser focus, and we're really focused on the net cost of that drug. There are several things that can affect the net cost. My accent just came out, sorry. It could be where we get it from, so whether it's from our international sourcing or domestically. It also affects that is the rebate. And there may be a rebate on that drug. How long do we need to wait for the rebate? There could be a 6, 8, 12-month wait for the rebate. So we always want to evaluate the net cost of that, and we're tracking that at all times. So if the net cost is more advantageous to move it back to domestic and move it back to even the health center, then that's done. Again, members still have their options, but we want to steer them and encourage them to use the best place possible. So we did have some drugs that were available on international pharmacy historically, and with changes in the formulary, for example, a drug might have a biosimilar equivalent to it now. So now we can get it domestically for a lot less expensive than the name brand overseas. So we want to bring that back domestically, have it sourced here, and a lot more convenient for the member as well. So again, we're tracking that laser focus on the net cost to the program and for the member.
And specialty drugs are about half of your pharmacy costs, but they're only coming from like 1 to 3% of your members. So, very, very few pills, so to speak, are, half your cost.
But every month, we've got a new Quali, Rizzi, Skizzy, something coming out of the pharmaceutical industry of, this brand new thing added to that and this and that. And a good example is Stelara. It was $22,000 a month domestically. We could get it for about half that internationally, and now there's a biosimilar that's $500 a month. So we have an outstanding PBM or pharmacy benefit manager who charges us a dispensing fee, but we get the true net. Unlike with an insurance company where they say you can have you get back 100% of the eligible rebates. But then deeper in the contract, they define what eligible is, because a lot of their revenue is coming from pharmacy now because of the limitations they have on the medical side under the Affordable Care Act. And the rebates that they get do not go through the formula prescribed by the Affordable Care Act. And this is why one carrier has bought Express Scripts. And in a perverse manner, Caremark bought Aetna. CVS bought Aetna.
Did he say
Excuse me.
Kmart? What? Oh, sorry.
Caremark.
Carolyn, what are some examples of specialty prescriptions?
Specialties prescriptions, and really the word specialty is very vague, because really the word defined, it can be defined in any contract. I would say it's anything expensive. So as he was just saying, Skyrizi, Sprycel, it could be some of your cancer medications. The big one that we had for a long time was Humira. Humira also had similar experience, what Barry was just talking about. The big one that we're having and we're tracking every moment right now is all of your, we call your GLP-1s, or your injectables for diabetic control and for people experiencing for weight loss. We've had a huge increase in the amount of GLP-1s usage on the plan. We've put some cost controls and limitations that are set by the manufacturer of you need to have a diagnosis of diabetes to be able to use this product. That helped us a little bit. We did some international sourcing. Then when we did a net cost analysis, we found out it's actually better domestically because of the rebates, so we moved people back to the domestically. The rebates can be for one drug versus another, so when they're equivalent, when we're having people change on what drug they're under, all to control the cost for the member and to help the cost for the plan.
It's also important to note, none of these drugs cure you.
Right.
They're maintenance,
managed.
quote unquote,
Yeah.
which means they got you forever.
Well, that's actually the question I have regarding the rebates. So I know that that's a great cost control measure, but is that a sustainable way to control costs?
Well, rebates are set by the manufacturer, and so so that's why we're always analyzing it. If the rebate changes, then we have to adjust what our net cost is and analyzing it from there. So it is a constant reanalysis of how the plan is, how it's costing the plan, and can there be any movement to help it.
It is a
How
perverse
long- Yeah.
platform,
It is- it
for
is.
sure.
It's a what?
A perverse platform. Why can't we just pay what we ought to pay instead of playing this game?
Yeah, that's the question. How long does the rebate, I mean, any drug at any point, average, how much does a rebate last for a specific type of drug?
However,
Changes all the
it
time.
changes all the
Because you're
time.
saying it's the management, it's the company that manages the, so like Terry, like my diabetic medication, I'm pretty sure, my pharmacist is pretty good about this, but we're looking at, what was that, 34, I'm now 44, so 10 years?
And you've had a rebate
I've
10
had a
years?
rebate
Okay.
every year.
Okay.
And I've had to change my medication a couple of times. My pharmacist will be like, all right, Cook, let's see if there's a rebate on it, and there has been available rebate. So a case for us, I've got 10 years where I've had rebates on all
There's
4 of my
Okay.
medications.
two different programs, and it's a great aspect for us too. That's on member cost. That's a premium, a coupon code or a coupon that's applied for the member experience. That's great for the members, and they get that at point of sale, but it doesn't affect the plan, doesn't affect how much we pay. The plan cost is affected by a rebate, or it's like your taxes. And you get your tax refund after you file your taxes, it's a check sent to you after your plan has used this drug and used this many units, they send you a check back.
Okay.
So in a way, we would ideally prefer, to
set price.
not send our more money to Uncle Sam and then get a refund at the end after he's had time to
Gotcha.
earn interest on it.
Okay,
So one is for you, so it's a coupon for the member.
Yeah.
And one is for the plan.
The plan, okay.
And we track both of them.
Yeah,
And Eric is great about looking for the coupons for the members to help them have their lower or no copay.
Your rebates under your prior administrator, which was an insurance company, were much higher than now, but that's because we've gotten the going-in cost way low. And the net is we're paying significantly less for pharmaceuticals than you were under the prior administration. Dr. Shanoff, you had a comment.
Yeah, quick question. How often is the analysis done on the cost of, say, where we're receiving these prescriptions, where we're purchasing these prescriptions from, these prescription drugs from? Do we do this analysis basically as day traders? Are we looking at it day by day, or are we
That's
looking
what
at,
it sounds
or
like.
no, or are we looking at it like
Almost.
That's what it
quarterly?
sounds like.
So
So,
where we get the drugs from,
well, I'm just curious whether or not, are we looking at, are we making those changes kind of on a dime, or are we waiting necessarily for, say, the quarter to end, and then looking at historical data and saying, okay, well, if we continue to buy domestically or through this particular entity, in another month, that price will drop historically? Or are we saying, you know what, we're seeing this shift now, we want to go ahead and we want to make the,
So there's a couple of answers to that, or a couple things to point out. Where the drugs are sourced from is really from that pharmacy, where they get it from their drug wholesaler. But we're talking about where is the person picking it up from, what pharmacy are they using, and we do that all the time. So we know that the cost to the Osceola and to the members is much better at certain pharmacies than others. We would like the members to stay away from the big box stores. And we have done plan design to encourage or disincent them to going to the CVS and Walgreens.
yeah, that's not, it's not, maybe I'm not explaining it well. I guess in order to control prescription costs for the program, we source from multiple different avenues, right? We source some internationally, we source some through co-op and whatnot. I guess my question is, you know, in a world where essentially it's controlled by the pharmaceutical manufacturers, these
More so the pharmacy benefit manager
Okay.
than
The
the
middleman.
than the manufacturer.
Got it, okay. Since it's controlled by the pharmacy benefit managers, I guess my question is, how often is the analysis done to look at where the lowest cost is coming from? Is that analysis done daily, weekly, monthly, quarterly? You want to answer that, Lauren? Okay. We got to get you a mic.
Yeah.
Good morning. So there's actually several different ways that we do this. Every day, Ventegra analyzes the cost of the drugs. So in the morning, they get what they call AWP minus whatever in the contract, and there's lots of numbers that I don't understand, but we have Ventegra and SkySail that does that automatically for us. And all that feeds into their system, and they figure out what the average is, and we get the least expensive of that average. So every day, if you go and get your Manjaro today, it's $405. Tomorrow, it could be $408. It just depends on that daily one. Then we also meet monthly, going over the formulary. We've been focusing a lot on anything that's going biosimilar, as well as anything that's high cost. So all the GLP-1s that people were taking for weight loss when they shouldn't have, because we don't cover that under the plan, it should just be for diabetics. We've been monitoring that monthly as well. And then we constantly look at the ElectRx formulary compared to what we could get it through here through Ventegra. So it's different ways. We're always looking at it. And then on top of that, Eric at Prescriptions Unlimited will say, hey, Lauren, this drug is now $5.99. Make sure Ventegra is adjusting that on there. So he's looking out for us as well on top of it. And like Carolyn said, we want our population to go to the best pharmacies that give us the deal, because it's not just the cost of the medication, it's also their dispensing fee. So the Walgreens and the CVS of the world make up their own dispensing fee. They make up their own price of those drugs. So that's why they're a non-preferred pharmacy. While Publix, Prescriptions Unlimited, Winn-Dixie, those are preferred because their dispensing fee is so much lower than anything else. Okay.
Also, Ventegra is working on some AI input right now, where when a pill is delivered at the pharmacy, whether it's Eric or wherever, there's an algorithm that will say, which source do we want to apply? And it'll shift prescription by prescription to source to the most cost-effective. I don't know how long it's going to be before they have that, but we've had active conversations with them about that.
Who's working on that?
Ventegra, our pharmacy benefit manager.
Okay.
So Carolyn wanted me to add one more thing. We have the VAP program on the back end too. So when Humira went to biosimilar, the manufacturer that Ventegra negotiated with gave us 3 months for anybody on that drug for free. So when Stelara did it, same thing. So at the same time we have a drug that goes down to $500, Ventegra is also negotiating so that we have a test run for those too.
Does that answer your question? It does. Okay.
Just a comment. There are very few employers and very few school boards in the country who are asking questions like this. You know, all they see is the big number, and why is it the big number, and let's change insurance carriers because we need a
And
lower
very
number.
few advisors that can answer the question, I might
Yeah,
say.
but thank you for getting involved and asking these questions.
We're not pharmacists. We partner with some very, very smart people who understand this and can explain it to us so we can explain it to you. But it's important to realize this is a whole industry, that there are smart people that track it, and we have a very trusted advisor group, not only with Eric Larson, but with Ventegra and their partners who really are aligned missions with us. They want to make a fair cost and operate profitably, but not, charge exorbitant fees in profit off of your backs. So we're aligned in our incentives with that.
So we're saying that someone can actually be on a medication long-term, and they're never really paying the full price.
Correct.
Because, okay, so that price is
It
pretty
could be
bogus.
zero.
Yeah.
It could be zero with coupons, yes.
Okay, understood.
And it's important to know that in our data, that's at point of service, so at the cash register, that coupon is captured. In our data, that coupon is not captured, so it still shows member cost, but we're not sure if a coupon was applied at CVS or not. We know that Eric in his Prescriptions Unlimited is probably doing that coupon, but we're not sure at the others.
I just have one question. Who decides these rebates? Is it the pharmacy benefit manager or the drug maker like Pfizer? Like, who is this magical person who's deciding this? I can't.
Capitalism.
The rebates are generally from the drug manufacturer.
Okay.
Of who applies the rebate. And then depending on, because we have a tiered program where we have a contract with Prescriptions Unlimited and Publix for preferred versus CVS as non-preferred, sometimes they have to negotiate extra for us because we have the steerage in there.
Yeah.
We wanted to make, when we were negotiating, when Ventegra was negotiating the Ozempic rebate with us, it was, well, if you put it on this such of a high tier, then they won't do the rebate for you. So those are all going into their negotiations, but we leave that up to them.
It's a game.
It is a game. It's literally coconuts.
Coconuts.
That's what it
Yeah.
feels
Yeah,
like.
the shell game.
Coconuts.
Yeah.
Jay, you want to pick back up? Sorry for the break.
No, this is good stuff. Yeah, keep in mind that the rebates only come on brand utilization. So those things that are advertised to you constantly on television are the things which you'll get the rebate, but ideally, we wouldn't get any rebates.
Right.
Why? Because we would be on biosimilars or generics or something to that effect, so that our base cost was really what we were spending money on, not waiting for some indeterminate amount of money coming back to us. And that's not insignificant, the money that comes back in terms of rebates. But ideally, in the big picture, you wouldn't get any rebates because we'd have everybody on exactly the platform that we want them
We
to be
pay a
on.
net cost that would be equivalent to the rebate up front.
That's right, that's right. All right, so now we're on slide 17, and we're about to dig into some of the numbers. I'm going to walk you through the very top line and then down the right-hand column. That's the orientation we're going to take here. This is fiscal year information, all right? And you'll notice that it runs from July of 21 to June of 22 through June of 2025. And you'll notice that our claim spend has been about $50-odd million or so, but this past fiscal year, it's up $10 million year over year. And today's conversation is about why is it up $10 million year over year. Half of it, we've alluded to, is due to the large claim activity. That big jump year over year in the incidence of claims at 100,000 and above constitutes about half of that $10 million. It's worth about $5 million. So working down the column on the right-hand side, the analysis here is to kind of drill down and try to figure out where's the pressure point? Where is this $10 million coming from? So the way I like to look at it is to say, of this $65 million spend, how much of it was due to the large claims? So if the paid claim is $100,000 and above, It falls into this circled bucket of 23 million, all right? The net of those two things, 65 million minus the 23 million, is what I've called the everyday claims, all right? This is the odd trip to the doctor, or the sprained ankle, the urgent care. It can include maternity stays. It can include everything that was normal, if you will, all right? 42 million. In this sheet, we're looking at things on a per member basis, per member per month. That is, could be children, could be the spouses, could be the employees, all right? Anybody who's signed up and enrolled and qualifies for care is a member of the plan, all right? There are currently 9,300 people on the plan.
When we added the health center only plan with the express purpose of allowing single parents and others to cover their children at very low cost, that's when we had an input increase in membership.
So if you take the $65 million and you boil it down to a per head basis, you'll see 586, all right, $586 per member per month. And of that 586, the large claimants, the $23 million bucket, constitutes 208, all right? 586 minus the 208 yields 377, all right? $377 per member per month is the everyday claimants. And then this is where we start to illuminate, of that, what is the other pressure point, all right? If we isolate the prescription drug cost, it is $125 per member per month out of that 377. And below that 125 is 30%. That's where this $5 million is coming from. Our pharmacy spend year over year, despite the programs, despite the efforts that we're making, is up 30% year over year. So when people say, why are we up $10 million? It's because of this on the prescription side, worth about $5 million, and the large claimants worth about the other $5 million. Okay? What's very interesting to me in this is that if you take the 377, which is medical and pharmacy, back out the pharmacy, you get the bottom number, which is 252. That is the medical spend. We are looking at medical and pharmacy. But the medical spend of everyday things, this is doctor visits, this is maternity stays, this is certain non-catastrophic hospital stays, it's gone from 275 to 277 to 253 to 252. Very, very flat. And yes, ma'am.
No, I was just looking at these numbers. Really what's driving up the cost are things that we in this room don't have control over.
We exercise as much control as we can, in particular over the pharmacy, but
Right.
you're right. If we have 40 people with cancer, we need to deal with it. You're right.
And we are fighting the RX, as Lauren mentioned. I mean, we're day trading on it, and we're doing everything we can.
But navigating that member to the right care, to a quality provider, to a quality facility that we know will be overall less cost is a way that we can do that. And so in helping in our contract negotiations, we know that we have a better contract with our big hospital system than the traditional insurance companies do. So that's really, really important to know too.
What you do have control over is the plan design, the incentives that the employees have to get care where we'd like them to get care, and that happens through the actual plan design. What's their out-of-pocket spend when they have an incident and they are about to engage the system, and what you charge them for the privilege of being on the plan.
So is that where we're seeing, I mean, I don't know if you're able to see it, but are the ones that are constituting these large, over $100,000 incidents, are they utilizing the doctors that would benefit them on our plan? Or are they going to care providers that they're choosing that are that higher cost, you know?
Carolyn, before you answer that, second layer to that, and you may not have that, the second layer to that I was thinking too, like, let's say I get cancer. Forget who you have in my network. If they're not top rated for cancer care, I'm going outside of that. So then my follow-up thought to that, as a second layer to what Heather was just asking, is do we know, it's obvious that we have some, to your point, those large claims, right? Do we know if we have those top tier providers within our network? And if not, is that something that we can put on the table to negotiate with those folks to start bringing down those costs? Because obviously we have a large claim. I see you creeping. I saw you creeping out my eye.
Pull up a chair.
For our reporting on the large claimants is we make sure that member is engaged with case management. So case manager is a nurse who's involved with their care, working with the doctor's office,
Carolyn,
working with the member
we need you in
to
the
make sure that they're
microphone.
accessing care.
We need you
Oh,
to
sorry.
speak into a mic. Yeah, thank you.
So when we get a list of a high-cost claimants, we always check to make sure that member is involved with case management. If they're not, if they haven't been involved, then we have case manager reach out to them and try to get them engaged with it. Some members opt not to be involved with them. And unfortunately, it's a great resource for them, but we can't mandate that. But they're still watching on the backside, make sure that the doctors are communicating with the plan and things like that. So as far as them working with preferred providers, we have to take a deeper dive into that.
Yeah, so 60% of those in case management are going to doctors that we recommended. If for some reason it's a doctor that we don't recommend and it's because we really don't want to recommend them, we beg them in all avenues as possible to move them to a different doctor. So we work as closely as possible with them on that. And I forgot the rest of the question now because Carolyn was talking. You're not getting cancer, but the first thing when somebody is diagnosed with anything and the team knows about it is how do we get them their best care? We're currently piloting an oncology program. I think it's in the slides up ahead, but we have specialty case management that does our kidney disease management, and they've successfully moved people that needed dialysis off dialysis up on their kidney level. So they went from a lower number so their kidneys weren't functioning all the way up to a higher number that their kidneys are functioning. So they've not needed a transplant, didn't need dialysis, and we've had them since 2020. They also have a cancer program, so we're piloting it now with them, and it's not just to save us money, it's to help the person and their family. So they're working with their doctors directly, like our cancer network is very good. We have top-notch in our network, so Moffitt, Orlando Health. If they're not in our network and we need to send them somewhere, we send them to, or we do a single case agreement. So if, God forbid, that happens to you and you want to go somewhere and we have to send you somewhere, we will. We want to make sure that we're using our partners first and then get the second opinion from the other ones on there.
And that's why I want to make sure our partner, because like I'm thinking like I'm the person that has cancer. I'm thinking about something that happened in my family. When I go online and I look, I don't care about our provider network. I'm saying best cancer doctor in Central Florida. That's who I want to go to. And then I start working backwards to see if I can get into them. And if our network doesn't cover that, I'm going to pay the extra money. And I'm thinking to myself, and maybe this is a little egocentric, I'm thinking to myself, that's how most people nowadays with access to internet are doing it. They're not going to call our nurses that are going to manage that. They're going to figure out, I want the best care. What is the best care that's local to me? Or how far do I have to go? And then are they in my network? And if not, then I'll pay whatever I'll pay whatever I have to pay.
And we appreciate that, but that was wrong. Because when you Google, they're paying for that ad.
That's right.
They're paying to be the
Well, and
first
that's
ones
part of the
on
problem.
there.
That's part of the problem.
While First Stop Health has an extensive database of who's board certified, who is specialized in melanoma versus this other type of cancer, who has the best outcomes. They have a lot more data that you cannot find on the internet, and they're going to get you to the right person. And we've had several cancer patients, they had to choose between Moffitt and Orlando Health, and they made their choice because they went to both of those at the same time at the beginning of their diagnosis, and they're continuing on it. If at that point they don't want to continue with Orlando Health or with Moffitt, then we will move them back to the other one. There's nothing stopping us for getting them their care that they need when they need it. So the Cancer Concierge program not only helps the member, like we had one member that was experiencing a lot of pain, and oncologists don't like to give out pain medicine, especially anything that's an opioid on it. So they helped that member get the pain medication to be able to actually sustain life, to be functional on it. And they gave them other options besides opioids to be able to help them control the pain, because a lot of these medications now that cost a lot of money just kills all the joints, kills everything in their body, and they just can't sustain it. And it's to help them. They also have text messaging capability. So in the middle of the night, they're not feeling well, they just text the nurses, and the nurses will get on the phone with them and say, okay, yes, this is going, did you try this, did you try that? Okay, no, your nearest ER is here. And they walk with them to the ER, they talk to the ER the next day and get them discharged earlier on anything that needs to be discharged on. So right now, and the program is fairly inexpensive per employee per month. It is a cost for us, but I think our overall return on investment is going to be more for the care of the person than the dollars to the trust fund. And I hope you guys know that that's what we try to do. That the first thing is always to look at what the member needs, how they need it, to make sure that they're better, because we don't want anybody to not be well on our plan. And
someone to advocate for them.
Correct.
Because there's so many care providers involved in their treatment, and someone who just listen to them and see what they're going through and to guide them with that is what I hear. We get chills just hearing the phone calls about what they're going through with the members. And another thing that's really important is we say it is a per member cost, but they are also advocating for the member on things like manufacturer's assistance programs for those drugs that they're on. So several employees, several of their drugs, they've applied for manufacturer assistance and retained it. So the plan is not paying anything for that drug, and neither is the member.
Or clinical trials.
Yeah, clinical
Clinical
trials are
trials as
available.
well.
They're looking for all of those clinical trials for them and offering them availability of that if the member is interested. Clinical trials we don't pay for either.
so there's a lot behind the scenes that happens in the plan that we're constantly evaluating, constantly looking at. When an employee comes to me, because I don't know everybody's diagnosis, I'm not supposed to know everybody's diagnosis, but if somebody comes to me for help, it's the first thing we do. We get them involved with case management with all the resources that are out there, but it does cost more. So to your point earlier, yes, we're doing a lot of education to our employees to get their mammograms, get their colonoscopies or yearly physicals, but at those appointments, they could find things. And then now that's why we have the 102 claims.
Yeah. Thank you for
Mr.
that.
Miniati, question regarding the 30%, which is about a 19% increase in pharmaceutical costs. What percentage of that 30% is our patients that are large claims? Do we have that number, or are we going to discuss it later?
It's separate from the other, it's separate from that. The large claimants are carved out and isolated in that 23 million at the top.
So this 30% does not include the
Right.
pharmaceuticals for those patients?
Correct. But
It's
when it
just
comes to,
everyday?
when it comes to large claimants, typically 95% of the spend is medical, not pharmacy.
Got it.
It can be the case that nowadays, due to specialty medications, a large claim can be a drug claim, but it's usually only a handful.
Okay.
Like hemophilia, where they're taking a drug that, as Barry indicated, it's not a cure, but it's an expensive maintenance type of thing. And yes, it can be expensive, but of these 102, at least 95 of them are medical.
Got it.
In our ultra-large claimant group above 200,000, we only have 2 people that had more than 10,000 in spend for pharmacy.
So I'm assuming that we're going to dive deep into the 30% where that's coming from?
Yes.
Okay.
Now, having said that, by the way, our analysis right now does not, about pharmacy for large claimants, does not include the J-code infusions because they're currently covered under the medical. It's another reason we want to get them out from under that so we can take a closer look at what's going on.
Now, this 30%, is that coming from the health center, people being
No.
prescribed there, or just in general?
The health center dollars, about $6 or $7 million a year, any of the drugs that are dispensed from there are not part of this. This is part of the medical pharmacy plan, everything other than the
And then
health
when
center.
we're looking at the data, are there any flags saying there's certain doctors that are just over-prescribing just medicine? I don't know if it's my age bracket, but I'm getting closer to 50. And every time I go to the doctor, they try to give me quite a few prescriptions for just multiple things, and I usually turn it down. But I'm just saying, like, I don't know if it's the age, but you get to a point where you go to the doctor and they offer, they're like, oh, are you sleeping good? Well, here, I could give you this, and, does your back hurt?
Paula, don't lean into
just
your
need
age.
magnesium.
That is just the time that we're in. There's a lot of
Pretty much let
You know
the
what I mean,
doctors
could that be
practice
contributing
medicine.
to the cost that we're offering, like people aren't saying, hey, I need these things, or there's a doctor that's, not that they're overly prescribing, but that you notice, like, hey, this person prescribes quite a bit of medication.
We monitor prescribers from the health center.
Yeah.
For certain things, but we really want doctors to practice medicine. And
Oh, yeah,
so-
I just
but we
mean in
are-
general.
We do track the opioid dispensation
Oh,
from
of course,
others.
of course.
But like John Doe,
Yeah.
OBGYN, as long as it's in range and it's medical necessity.
Okay.
Every 2 weeks, our entire platform of partners gets together to review the claims of the people that are active or potentially high cost.
Any other questions on slide 17? All right, now on 18. The two columns I'd like you to really refer to here are the one far left, K through 12 schools benchmark, and then the far right-hand column, which is, again, the fiscal year. And this is where we start to take the medical and the pharmacy and try to break it down a bit more. And the key of this exhibit is to compare your group year to year within itself to the benchmark, all right? So below the middle there, the inpatient per member per month expense. The benchmark is 106, and for the last several years, you all have been in excess of that.
If I could just say one thing about the benchmark. The benchmark is a national benchmark of all schools K through 12. So it's important to know here that Florida is one of the most expensive places for medical care in the country. We are either number 1 or number 2 states for cost of medical care. So when we see
We're number
prices, we don't want to say brag about that, but prices versus episodes, we talk about how many episodes of care they had, is a little bit different than price point because we're comparing many different states and schools.
Why not benchmark to Florida schools then, just instead of national?
We can benchmark to the Orlando metropolitan area and broadly, for all private and public. We can benchmark for the Southeast, but we don't have a benchmark that includes Florida K-12.
Okay, but you can benchmark to Central Florida?
Yes.
Okay, I think that's helpful.
It just gets, the population becomes, because we want to have a group your size, and groups domiciled in Central Florida of 9,000 members, our comparability groups become very small.
Understood, except that the health, our health plan is part of our total compensation, and if we're making decisions on how we're going to change it if we need to, that's going to affect how competitive we are with the rest of Central Florida. So I think that would be helpful, even though it's not, the data may not be as clean. Maybe we can have both sets of data points.
We've done some very deep comparison to the 5 or 6 school districts right around you.
Yes.
And we're going to address that.
Oh, so it's here somewhere. Great, love it, thank you.
some of these numbers are not necessarily bad. I would say that it makes sense that the outpatient PMPM, we would like to see more things done in the outpatient setting than in the inpatient setting. So we have traditionally been below the benchmark, but this year there's been a big increase in the outpatient PMPM. It's now 204. The benchmark's 174. So again, that's a steerage type of success, if you will, that we want to draw attention to. Office visits, $89 is the benchmark PMPM. We've traditionally been in excess of that, but it's fairly flat over the course of time. Again, we're promoting preventive care. People can get that in the outpatient setting. The medical claims, they are in excess of the benchmark, all right? A lot of that has to do with the large claim incidents over the course of time. We've talked a lot about the pharmacy PMPM and how here in this group, 78 to 86 to 96 to 125, it's on a rocket. It still turns out to be less than the benchmark, but moving in the wrong direction. All right. Questions about this page, what we're trying to get? I certainly think we can refine or narrow down the comparative, whether it's commercial and public in the state of Florida, et cetera, to give you all a better sense of things on that.
Jay, you said we want to see more of our employees in outpatient over inpatient care, yeah? Okay.
To the extent that it can be. Obviously, medical necessity and emergency situations, you know, go to the ER. But if you can really think twice about going to the urgent care center, teledoc, you know, that type of stuff, we want to promote that. And when we describe things that are within your control, and Lauren has alluded to this, the messaging, the reminding, think of this first when you need to engage the system. Think of it before you have the need. What's your game plan when you are needing either, you know, your kid hurts themselves on the playing field, or you're trying pickleball for the first time and it doesn't go terribly well? You know, what will you do if something happens? Have that game plan already structured and set up ahead of time to understand the best way to engage the system. And that can be messaging. Now on slide 19, further drilling down into the different aspects of things. ER visits. We talk about place of care. You all have consistently been over the benchmark. People use that as their first choice as opposed to urgent care. If we're going to message something, let's say, hey, think to not go to the ER, think to go to urgent care, and plan designing has been done around that. There's certainly an expensive ask to go to the ER as defined by your plan design. There's an incentive to go to urgent care, financial incentive. That's already been built in, and yet somehow the message is not turning into action.
Do you think like parents know that, or family members? Because I know like when my kid was itty bitty and something happened, my first thought is straight to the emergency room if it was like catastrophic. Do they even know that's an option?
Oh, yeah,
You've been teaching it.
Yeah.
one would hope so,
It's like
yeah.
a big
But also, you know, we talk a lot about the social impacts on healthcare, and unfortunately, realistically, if you go to the urgent care, you've got a copay. If you go to the emergency room, there's a huge out-of-pocket, but way too many people ignore that and just don't pay it. It's just part of the economics of the environment.
Or do you think
I
it could
think
be
it's
like where they're
message.
from? Like maybe wherever they initially came from, that maybe that is when you have an emergency, that's where you go, and I wouldn't know, like say you were from another country and you thought like something catastrophic's happened, emergency.
We've
room.
been, I would call it very deliberate about our marketing of usage of urgent care versus ER. In fact, that
Or
was
the
one
health
of-
center.
Pardon me?
Or the health center.
Or the health center, or telehealth. I feel like we get, I don't want to say this and it come out the wrong way, Lauren, but I feel like we're getting inundated a lot with a lot of that messaging coming from risk and benefits, we get a lot of the, if you can, go to this instead of this. So, you know, I already know that if my child gets hurt, I'm first going to urgent care before I'm going to the ER, just because that seems to be the message that we continue to get from risk and benefits via email, via text, via everything. It seems to be a fairly consistent message. Have you not been getting those messages? We can get them to you.
Maybe I just delete them. I'm just saying, like, I'm a longtime employee, maybe new employees or the young people coming from college or, you know, whatever, young mothers, or maybe
I'm
they're
older
not
than
aware.
you.
Oh, well, I do. I'm just saying, maybe
I'll
that's,
put myself on the chopping block, as I just did with my last example when Laura, I put in my notes, Laura clapped back at me. When my oldest had his concussion, urgent care was not anywhere in my vicinity of thoughts.
No,
Straight to the ER.
that's appropriate.
You know what I'm saying? But I'm thinking about I'm thinking you have generations of this is what you do, this is a practice, this is a habit. So I was even gonna ask, like, how many years have we been talking about this? Because let's say it's been 2 years, let's say it's been 3 years, that's not going to change generational direction of what happens, right? So I think that just undergirds, we need to continue with that messaging. Maybe we need to think about or reassess how it's getting out, what it looks like. But I'm even thinking about our population here within our district. Like, I think it's going to take time. I don't think it's going to change over a couple of years. I think it's going to change over several years for that to happen, and not just with urgent care versus ER. Where I've taken notes on a whole bunch of stuff. I'm like, I need to call Lord. I need to get better at some of this stuff as somebody that needs it, and as a parent, like, I'm like, oh my gosh, there's so many layers and I've been in the district for 20-something years that I'm like, okay, I have to get better about this. So even
I work for the fire department, and we see it every day. People call, they don't know how to identify an emergency from an urgency. Like, just to give you an example, 911 call, the girl just scratches in her knees. And we have to educate people, and I think that's the message. Like, sometimes they just call because they just need transportation. They don't even, that's not even an emergency, it's just transportation. I need to go to the medical and get some help, but they just want us to transport them to that place. So I think it's about educating the community, like that's my other job, but that's what we're doing with the little ones. When we go to the schools, we tell them, this is an emergency. Do we call for this? And I guess the adults is the same thing, because it's as you say, first thing that comes to your mind, I'm gonna go straight to emergency. Because for me, this is the concept. People don't understand. Why you think it's not an emergency, for them, it's an emergency. We call it the worst day of their lives. And that's what we have to go deeper and see. I know you mentioned that we're sending messages, but I don't know, comparisons, videos, or if you want to come to the fire department and kind of like have someone explain it and do some videos about that.
Like infographic, like broken arm, you know, blood head.
We can, I mean.
The way I teach the kids.
The emergency room.
No, the way I teach the kids, and I always say, if you see the bone, and they're like, oh, miss, and they like, but that's an emergency. If it's a scratch, no. And adults, sometimes it's a simple message, but if it's visual, and it gets probably more effective.
It's a very
Go
fine,
easy on me, you two.
It's a very, I appreciate it. I appreciate all the comment. It is a very difficult needle to thread when you educate people about where they need to be going, and essentially telling them how to judge a particular situation. It becomes a very difficult thing to message. So the way that Lauren's team messages what's available, I think has to be done in a very judicious way, because you can't just compel people to use telehealth for this, to use emergency, or to use urgent care for this, to use an emergency room for this. It becomes really difficult, because then at what point are you taking the choice away from individuals? So the bottom line is that, you know, we can go ahead and dive deeper into open rates when we send out these informational messages and those types of things, but it becomes a very fine line when you start saying, no, you can't go here for this. You have to go there. That becomes difficult.
It's really a
Can't is not
self-ass-
in our vocabulary.
It's really a self-assessment to that parent, because we're going to be panicking. Our kid got hurt somehow, and this is where we think it's going to go. And to me, that's an appropriate reaction, because we can't assess that at that point. So let them go to the ER if they need to go to ER. There's a lot of urgent care for children in our county, and same as hospitals that they can go to that are on our plan. But back to Dr. Channel's point, we have a benefit education specialist that we created a couple years ago. So that's why you see all that communication that's going out to our employees. To your point, Ms. Bronson, we go to all the new teacher orientations, all the new hire orientations, and educate them at that point. Okay. We know when they start, they're being bombarded with all the information, right?
Yeah.
That's what happens. So one day they have this, one day they have that, and then we are 15 minutes between their courses. So they're not going to remember that. So we go out to the schools as well. We go to the events. We have blender-like events with our wellness one. So we try and do as much as possible besides the electronic, the emails, the text messages. We're talking about doing podcasts with our vendors as well. We have videos that they can watch later if they want to do a course. Orlando Health does a whole wellness series for them as well. So we've seen that participation come up, but it's only as good as the person that wants to listen, wants to read it. So sometimes they don't, and that's okay. And they'll go to the ER, and again, that's okay. But it's all the constant education. So they might learn that from their neighbor next door. Why did they go to the televisit or Orlando Health that's free instead of the urgent care that's $45?
Yeah, I think another thing is I've been contacted by staff members who are parents, and they have drove all the way to Nemours and then are upset at the cost later. I don't think when they get admitted or they're starting that process, and I'm not saying it's just young parents, but I don't think they're aware of the actual cost. And I think maybe if we just presented, if you came here, not that we're saying it's better or making choices for them, but make you aware of the cost ahead of time. Because then people are blown away by what they are expected to pay.
Yeah.
And
We
they're
have a
asking
where
family
to-
members to help them pay these medical bills that,
Yeah, we have a where to go flyer that has the costs. So the ER is.
do we?
Yeah, we do. It says unknown. There's one for urgent care that's $45,
Okay.
and televisit is $0. Exactly. So we do have that. Again, it's just, did you read it? Did
Put
you
those
see
in the
it?
break
It's in
room
front
or
of you at the
something.
time. It might not be. We have magnets
Put it by
that
the
go in your
copier
refrigerator.
machine.
We have a lot of different avenues. And again, it just depends on that person at that time. But instead of going to Nemours, they could have gone to Nemours urgent care at the Loop.
Yep.
Or the new Loop, or whatever it's called, right next door, so. Nightlife Pediatric is on 192. There's a lot of urgent cares. The bad thing about urgent care is they all close around 8 o'clock at night.
Yeah.
Some of them don't have Saturday hours, some of them do. We just can't control that because that's their business, it's not our business. So if the child gets hurt after hours, then they should be going to the
Can
ER
I just
anyway.
call you directly for
Absolutely.
direction?
Everybody does, so come on right ahead.
Recommending.
Lauren, I got a
just
little
all
issue
call
in my
Lauren.
head. Who should I go to?
Absolutely.
Okay.
The amount of those ER visits could be from our patients that are having cancer treatment
Yeah.
and have cancer care also. So if they have symptoms that are going on because they're in treatment, they could become dehydrated or something like that. So again, looking at that on a more of a global basis, but you see how it's been creeping up each time.
And a lot of these on this page are related. So if there's a lot of people going to the ER, it only makes sense that there could be admissions from the ER, and we see that that is creeping up over time, but certainly more than the benchmark by a wide margin. Total admissions overall, more than the benchmark. 30-day readmissions, this is when you go in, you have something done to correct, it comes out, and it wasn't totally corrective, and you end up back. I mean, that to me is something that we draw attention to try to limit that as much as we can.
We're doing an analysis on the 30-day readmissions right now, and so we have a meeting with Orlando Health and the other providers about that. And some of them are exactly for that, the cancer treatment. They had a cancer surgery, then they had another follow-up cancer surgery, and just happened to be coded as a readmission. But we are doing a deep dive on the 30-day readmission ones.
The urgent care visits, when we see that improving over the course of time, but obviously still a lot less than the benchmark. And again, that's why I say these things are interrelated. If we're over on ER, we're under on urgent, and we're seeing it's the opposite in other groups. Dialysis services, that's one I would think would be a good news one. I think, Barry, you want to color that one a little bit as far as people getting the right thing and getting off dialysis.
Well, that's why we hired specialty care management who are dialysis specialists. And and these people, I mean, they talk to these people 2 or 3 times a week. And they do the same thing under the cancer program that we're piloting right now. And, you know, a year's worth of dialysis at retail could run $900,000. They have specialty contracts, and we monitor them so that as soon as Medicare is willing to take over, we transfer them to Medicare. It's a very active process.
The last line is not a good news line, and it's one of the ones that contributes to this pharmacy spend, where there have been improvements over the course of time, at least within the group, as far as the number of prescriptions written, but you can see it's 50% higher than the benchmark. There's just a lot of prescriptions being written. We don't have in this exhibit or the appendix what the exact names of those drugs are. We have that information. We can share it with you to say, this is the incidence of this drug being prescribed here within the district, just so that you get a sense of the names. None of the names make any sense, but you'll get an idea of what conditions, whether it's hypertension or anxiety or cancer-related, we can tell you what that is.
Yeah, I think that's actually really important, because if we see that there is a specific issue within our population, then we can better, work on a strategy to fix
Absolutely.
it, or help fix it.
Absolutely.
I mean, if it's mental health medication, so I think that I would be interested to see what the incidence of these medications are.
Physical therapy here, where it's got a decrease, I'm concerned about that. Is that because it's on Simpson Road and it's hard to get to? Is that the only place that we're offering physical therapy? Or
There's physical therapists in our network, so
Yeah.
it could be at a doctor's office or a facility at a hospital. So there's our whole network of physical therapy too. We want to encourage them to use
Yeah.
the health center, because we pay for that in advance and they don't pay anything for that. But there is a network outside of that too.
And then the chiropractor, we only have one.
We have one on staff
Yeah.
at the health center that is very popular.
Yes.
He's a very appreciated
Dr.
member
Michael,
of
he
the
is a
health center team.
delight. I enjoy him.
Yes.
I
That
do.
does as well?
I do. Anyway, getting an appointment with him, I don't know if you look on his schedule, there are none, because he's so popular and there's not a lot of options. And so you have to go a month or 2 out, and just being in education, the flexibility there to get in those appointments is not available.
There are
So-
many employees that are like you, that like the regular appointment schedule.
Yeah.
And so that's constantly being reevaluated. And if they want to bring on another chiropractor and what that expense would be up to us to evaluate if it would be worthwhile, if it's needed.
We're also having an east and west option for people. Oh,
Yeah,
well,
so
sooner than later.
physical therapy at the health center is actually up. There's more participation. This is the data for the entire plan, so it's people just not going out to the community. So that might be because they can't afford to copay in the community anymore, so they're coming back at the health center on it. The health center has been double booking for the past year or so for the people that were no-showing because they had a high no-show rate, so that's been successful as well. If you take up that spot and we weren't double booking, then they would just be sitting there not doing anything, and another person could have taken that spot at the time of the physical therapist. For the chiropractor, right now, to me, it's more a space issue to add a second chiropractor. We would have to have different hours than Dr. Hughes that he has right now, and the health center's not open that late, and we don't want somebody alone at that point on it. So we are looking at it. He's super popular, and we have some people that might not need to go to him every week that are going to him every week. So the health center is evaluating those patients to see if they can graduate them. I'm not saying that's you, but there are some people that are.
No,
that
I
just,
can't
just,
even get in.
Just want to be
I'm lucky if I see
adjusted.
him once every 6 months, but like
they're-
schedule-wise, it's always full and.
Yeah, there's people that they'll leave and they have the next 6 appointments booked up already in advance.
Really? And what is their secret to that?
I don't know, but they do. So those people are being evaluated, so he can see. He has been seeing more patients overall, unique patients from year over year. But again, they still need to evaluate that for us right now. So it's space and evaluation of the patients that are coming in for Dr. Hughes.
So I've taken you into the weeds and the depths of things. The last slide that I have to discuss is number 20. And this is really the big picture on the plan. The far left column is the current results. Your plan is governed by Florida Statute 112.08. It oversees self-funded public entities, and it requires annually a report of actuarial soundness, and that's where I come in. We have to put aside 2 months' worth of claims in surplus, all right? And we go through, I work with Sarah very directly in this regard to figure out, do the math, go through the state's boilerplate format and say, okay, well, what does that turn out to need to be? And then we have to move money out of general operating expense from the district into this earmarked fund so that we can pass muster with the state's review. All right. The 3 columns to the right are my projection for what I think expenses are going to be if we don't make any changes to the plan with regard to plan designs or your share or the employee share. All of that is the status quo if things were to go the way that they are today. Any questions on this or any of the other exhibits that we've discussed in the actuarial review? Okay. Thank you.
So that. Thank you. Oh.
I go to go.
This is your plan. It's not mine.
It's definitely a team effort. We meet because everybody has their area of expertise, right? Just like in education, everyone has their area of expertise, and the team gets together to manage all of this actively for the school district. Barry, why don't you provide an update on some things that we are doing in conjunction with the plan? So this is
It's difficult in a year when you're experiencing a large increase in claims to talk about the good work that's been done. So I'm going to highlight a few of those things, but before I do that, Dr. Shanoff, you started off the meeting saying that what we had here was unique. And I want to emphasize that. You know, I've been doing this 53 years. And up until about 15 years ago, I was just like any other broker, providing a shopping service, and maybe I'd help you with compliance or some, technical issues. But about 15 years ago, we switched over from broker to advisor. And I met Tim Wishire at the FSBA in 2018, and he had shared that, you know, that the county or the district was struggling, and I offered to share with him what I'd been doing in Southeast Georgia for a while in terms of direct communication and fundamentally getting rid of the middleman, the insurance company. Because at Orange County, your insurance carrier says, here's what we've got, what do you like? Our approach is, some of this makes sense, some of it doesn't. You know, when I looked at Jacksonville, Florida, in St. Vincent's Hospital, a knee replacement was $68,000, and at Baptist it was $42,000, and at Mayo it was $28,000. But I, as a member, I have the same $5,000, call it, out of pocket no matter where I go. And the insurance companies, they're more than happy to pay whatever is billed because they're using your money. And we came to realize that insurance companies don't pay claims. They process claims with your money and your employees' money. And there's so many layers of profit in that I determined, again, about 12, 15 years ago, that we needed to get them out of the middle and let neighbors talk to neighbors and providers talk to consumers. So a couple of things I want to say. That board at that time was very courageous because they'd never heard of this kind of an approach before. We had done it with 200 life groups and 90 life groups and that sort of thing, but not at a grand scale. And then I met the folks from the Rosen Group with their unique ability on the clinic side or the health center side and what they'd been doing. So we thought it made sense to merge together and offer an integrated approach to managing your overall health plan. I want you to know you cannot get this with an insurance company. We had to fight like crazy to get access to the data so we could do the proper job of looking at it like you see we are looking at it now. Now in the industry, bits and pieces of what we are doing are showing up at other places, but to have a totally integrated platform with specialty providers focused on reducing barriers to care, direct contracts where we can. How is it that we're able to get a better contract with Orlando Health than the insurance companies? Think about it, you know? And they're willing partners. Lauren can talk directly to the people at Orlando Health. You can't do that with an insurance company in the middle. So I've said enough of that. The other thing I would say is the courage of the board, the uniqueness of our approach. But I would say I would put Lauren and her team up against any benefit advisor in the country. They'll approach her and she just shoots them down because she knows more than they do, because this is an infinitely actively managed program. Now, that's not to say that we're immune from the forces in the nature of your population. You know, we've got 800 diabetics. That's just a fact. We have close to 400 people with some form of cancer at one level or another, and we have to deal with that. But what I want you to hear is, and hopefully you've sensed from this meeting, that we are on top of this to the very degree that is possible to minimize expense of the plan, maximize benefits for the employees. So on slide 22, when we got here in 2019 and we reviewed the previous plan year, the spend was about $64 million. We also determined that for the last 15 years, you know, the rate increases were just an avalanche, 6%, 9%, 4%, 15%, 22%, but they averaged 6%. So on this slide, we ask ourselves, had you stayed where you were, where would you be today? And we had to assume that the 6% historical increases were going to continue. And we look at that versus our results, and we think over the last 6 years, we've saved the community or the district about $72 million. In spite of the fact that this year we have this huge bump. And what we've tried to show here on this slide 22 are some of the various areas where we've saved money in rebates. The ElectRx, again, now this is kind of unique to our plan. Humira is $5,500 a month, or was $5,500 a month forever domestically. We could get it for $2,100 a month. Why don't we encourage the employee to use ElectRx International by waiving their copay? If you want to get it domestically, it's $150 a month, help yourself. But if you're willing to participate in the international pharmacy, you get it for free. This has to be us aligning member outcomes and plan outcomes together.
And then when Humira, biosimilar, we move it back to domestic.
We make them Hera.
Yeah.
Right, when they play. The chronic kidney disease program has saved well over $1 million, about $165,000 this year. The opioid clinical management, that's something unique that we put in. And what our partner here does is they don't go to the member who's using the opioids. They go to the doctor community that's prescribing them and educate them that their prescribing patterns are outside normative procedures. And we've gone from 254 members who were at high risk for opioid addiction. We're down to 46, and we're monitoring them. But again, savings to the health plan is only part of the story, because at the same time, if you look at the next page, we have found a way to save money for the members. And some of this is to induce them to make better decisions. If you make better decisions, you have lower out-of-pocket costs. Again, aligning their best outcomes with our best outcomes. The on-site pharmacy, it's hard to pay a copay because, the drugs don't carry a copay there. ElectRx, again, we've saved hundreds of thousands of dollars for your employees and their families. The direct contract with imaging, when we got here and we reviewed the imaging expenses, we saw CAT scans for $37,000.
So Barry, if I could add, this 49 for the on-site pharmacy is only the waiver for name brand medications. It's not taking into account generics that are zero, because that goes through.
Right, that are free. Thank you for that. But we found people were not getting x-rays or MRIs because they couldn't afford it. So again, we created a direct contract through an intermediary who really basically purchases excess time, unscheduled time at the imaging centers for a very deep discount. And that's how they do it. And then if the employee goes through them and they handhold them and schedule it and make sure everything's okay, then the imaging is free. So we now have people adhering more closely to those things. The mammogram bus, and now we have a dermatology bus, is a huge home run. Very inexpensive cost of service, added convenience.
When you talk about dermatology, if you ever tried to get a dermatology screening on your own, it's about a 6-month wait for a dermatology appointment. So bringing that on site is so valuable for your people to get that. It's quick. If any of you have done it, if you haven't done it, it's very easy to schedule. You're in and out a couple minutes, but could be life-saving. And I think Kenneth's going to go over some of the numbers on the on-spot, because we've caught some pretty significant situations out there.
And the mammogram,
Dr. Shannon.
oh, excuse me, go ahead.
I have used the dermatology bus twice, most recently at the Keeping Pace with Wellness event. Fantastic service, very quick, very efficient, and they do great work. So I have to say that, and it seems like no matter where I go on my travels around the district, the dermatology bus just pops up everywhere. So it's great to see. The value, I think, is really in the mobility of the service. So then folks that are in, say, Poinciana or out in Harmony, they can get the benefit of the dermatology services without having to come over to a Simpson Road or something of that nature. That I think that one thing that we've really seen is the value of these mobile doctors' offices. It has been transformative, and our employees use them at a very high level, and I think that it's been great. I actually prefer it.
Access to care.
You're in and
Yeah,
out.
I prefer it, yeah, because I am in and out. Nobody wants me on that bus any longer than they have to.
It's a
And
nice
I don't want to be
bus.
on there either.
It's a nice bus, but you
It
don't
is a
wanna
nice
be-
bus, but I mean, that's, yeah, so.
Yeah, I would
Thank
like to
you.
say, I've also used the mammogram bus, I use that every year, and the dermatology, and I just added the vision.
Ooh.
I know.
Right.
We have a mobile vision one?
I just used it,
Stop.
and it is lovely. Everyone on there
We'll
is,
send you info on it.
it was
I have
easy to
used the
schedule,
mammogram. I
you know,
love
like
that.
you don't have to mess
Yeah.
with the insurance, because they know
in
it
a
already, and you
waiting
just, it's easy to use.
you got an appointment.
Yeah, shout out to the mammogram bus.
Yes.
And the
You're in
mammogram,
the
Lauren
waiting
is such a tough negotiator. She got the people running the mammogram bus to cover the cost of a substitute teacher to free up your teacher to go get her mammogram.
What? Lauren, where are you?
Wait, what? Say that again?
Yeah, say that again for the people in the back.
Yeah.
We're working through the logistics, but we've piloted, I think, at one school, because it's not a substitute for one class. It's a substitute for multiple classes, so they have
Yeah,
to
so they
go
move
around. Like,
Well,
so
that
it's
is
Still
lovely.
amazing.
Yes.
That is great,
Okay.
because like during school, you're always trying to find a partner or somebody who doesn't have a
Correct.
lunch to watch
Yeah.
your kids so that you can get, because you just take whatever appointment you
We
can,
heard
you
over
can
and over
find.
again that they couldn't go because of
Yeah, and
coverage.
I don't want to take complete credit. It came out of our benefit committee. One of the retirees said, why can't we have a whole bunch of retirees volunteer and go to the classroom while the women go get their mammogram done? But instead of getting the volunteers, we just have them take the class.
That's great.
That's a big win. Well done.
I love the volunteers retiree, because for them to go back into the school, you know, for a day to go back to their old school, whatever. is a
They'd
nice
like
thing
it.
to do. Yeah.
So I wanted to just touch on those things. First and foremost, you know, Lauren and her team have done a great job to get all these buses to all of your locations. I mean, I think you have 65 locations. But, you know, I want to give kudos to this board and also the previous board to take that step, especially on the mobile dermatology, as you heard Carolyn say, 3 to 6 months to get into a dermatologist. But also, you guys won an award for finding your first melanoma. I think it was in the first month.
About 2 years ago.
Yeah, in the first month. But you found 8 melanomas for your district. So you're saving lives. I know there's a cost associated to it, but look at the lives that you're saving and changing and bringing these benefits. But look at your mammograms. I mean, the previous slides. Your slides are showing that your mammogram utilization, we're going to find stuff. But it's these kind of things that we're doing, bringing the care to your members, and Lauren and her team bringing it to the front step and bringing in those, not volunteers, but those people to help cover is what is the game changer. But this makes a difference, and you saved 8 people's lives and counting.
Yep.
Mic drop.
And again, they went in there as a screening, preventive screening. They had no symptoms or anything like that, and, you know, they found it and were able to address it and affect the rest of their lives. Ashley, you want to go over?
Yeah, we're now at the end, but we do have an entire appendix, and the reason why we had that is because Terry happened to have a question.
I was about to say, shout out to the appendix. I was looking at it. This is good stuff.
Terry, you had said, you know, what are some other benchmarks in the area? So if there's a lot of slides that you can look at, but on slide 40, if you can turn there, you'll see two columns for each school district or each plan. And the column, the first column is the number of covered employees. But I want you to focus on the cost. And you'll see the cost, SDOC at $8,170 versus Orange County had 4 plans that averaged about $12,000. Lake, $9,500, Brevard, $11,500, Seminole, $9,500. And so you have the lowest cost plan with a much richer benefit than most. And so that's really good
Good
stuff.
stuff.
And these numbers
Thank
are
you.
all from public records, because they have to file this code section that Jay
They were done
spoke
through
of.
public record requests.
Right.
So in the previous slides to that, slides 35 to 40 are all different benchmarks. What's the employee payroll deduction? What's the employee spouse payroll deduction? All of that, Lauren, do you want to go over that?
This data is old because it's from 2023, but we're still in the same competitive mark because everybody else is also increasing their premiums for the employees. So
Say that one more time, Lauren.
so all the other districts are also increasing the premiums for their employees. I say it three times, but not everybody believes me when I say that, so, okay.
Yeah, third time's a charm.
Other school districts are more in the hole than SDOC is because they don't have the quality controls that we do around it. So
They're
I'm
moving more
actually,
money.
I'm supposed to be this week at the FIRMA conference. I went yesterday for the first day. So the FIRMA is the Florida Risk Managers Association, and on the first day, people were surprised that there was spread pricing on pharmacy, and they were wanting to talk about spread pricing on pharmacy and who they can sue. So, yeah, we're doing things a lot ahead of them. Lake County Schools started off slowly. They added one plan to mimic ours, and now they're learning more as they go. Polk County Schools is kind of doing a little bit coming up as well. Orange isn't there yet. I know Ashley talks to them a lot, but they are watching us. They don't like us speaking at that conference because we don't have the same
Who's the sponsor?
Doctors.
Who's the big sponsors at the
a
conference?
lot of them that we used to do business with.
Insurance
Yeah,
companies.
the
So-
insurance companies. and
Insurance
the big
companies. So
broker
whoever
houses.
gets to speak is because they sponsored something. So, anyway,
as it relates to-
yesterday was a roundtable with the school districts, and that's what I mean. They were surprised of the spread pricing and what they can do on it. So things that we've been doing now for 5 years, they're now getting into or may not even get into because a lot of the other school districts were just not know, they don't know their data because a lot of them don't have their data like we have our data. So when we created the health center plan, at the time, we heard a lot from our employees that Orange County Schools, thank you, sorry, Caroline, Orange County Schools was cheaper than ours. So we purposely put in the need for a referral to control cost. So that when a person goes to the health center and they're on the health center plan, they have to have a referral outside because there's so many things that the health center can do as primary care doctors that they don't need to get done out in the, you don't need to go to cardiologist because you have high blood pressure when your primary care can control that. And that's one of the big things in our school district is high blood pressure and GI issues, and they can service those out of the health center. It's because teachers can't go and bus drivers can't go to the bathroom because of their schedule with the kids. That's why the GI issues and the blood pressure is, they're not drinking enough water, they're not doing what they need to in that case because they can't, again, go to the bathroom. So we look at all those statistics and how we can improve and get them to get the care that they need. But my point is why we created that plan was so that we can be competitive with all the other school districts. And as soon as we created that plan, Orange County Schools increased their premiums because they weren't sustainable either. So Orange County Schools has premiums for tenured teachers before a certain date, and then different premiums for new teachers after a certain date. And even though the tenured had an increase at that time for Orange County Schools. But we look at this, and I didn't realize till the other day, Sarah said that Volusia's not on here. We should have added the Volusia. We'll work on that for this next school year. But if you compare our benefits, not just in the premiums, but all the added programs, our benefits are much better. And I know I owe you this. I had found a file in my drawer from the previous director that had the Affordable Care Act, what's it called, the grading level, and our plan
Metallic,
increased from 10 years ago to now, increased in the value of it. So our benefits have just gotten better over the years at lower cost.
Two things I heard.
Yes.
One, I heard a lot, but I want to highlight these two. I want to highlight these two things. One, I heard you say all of the school districts are raising their premiums. Two, I heard you say, not in these words, so this is how I interpreted this. As it relates to fiscal responsibility in this area, we're doing great, and we're not sacrificing our quality of care for our district.
Correct.
Okay.
And we are fiduciaries of our plan. So that's why we're constantly monitoring. I know that you've probably seen in the news over the last couple of years that several big companies are being sued by their employees because they weren't fiduciaries of their own plan, meaning they weren't getting the best price for that medication or the best price for that doctor on it. So that's a big thing in our industry right now. Are we being the proper fiduciaries? So that's why we look at every single number every time we meet, and we meet all the time. We might as well live in the same house.
Well, trust and verify.
Exactly.
Trust and verify.
So, and also, the cost of care is just going up,
Yes.
right?
Especially in Florida.
So if we look at the cost of care and the increase in the cost of care, and we overlay, you know, what we're having to continue to pay year over year, you know, how does that compare? Let's even say, I mean, I think that Jay has done a great job of saying you have this bucket of claims that are $100,000 or more, and we need to look at those separately. But in looking at those types of claims, the cost of care for those types of claims have also increased astronomically as well. I think it would be interesting for us to be able to potentially see an overlay of the industry costs around those large claims, and seeing what our increases are relative to the industry, and then also taking a look at some of the other factors. I am somebody that went from the Wellness Advantage plan to Health Center plan last year.
Don't do that to him.
And yes, there are things that are different that may be a little bit more restrictive. I needed to get a referral in order to go to the on-spot dermatology. I didn't have to have a referral previously in order to make my appointment. All of those things, though, and when I call, I say, I don't need an appointment that's going to fit the superintendent's schedule. I'll call 3 months ahead for my physical to set that time.
What?
If I'm sick,
Somebody people do that?
if I'm sick, I'll go to telehealth as best I can, right? So, but what I found is that, you know, the folks that staff the health center are incredibly responsive. We have very good ratings coming out of the health center. And I also carry my child on my insurance. And obviously, you know, pediatrics is not something that we have within the health center plan. So part of my concern was, well, will my child be able to be covered going to their doctor under our plan? And we have not encountered a doctor, a primary care, her primary care, or a specialty that has said, no, they are all taking what we offer. So if the concern is, I'm going to move off of Wellness Essentials or Wellness Advantage, and now all of a sudden my kid isn't necessarily going to get the same level of care, I'm not worried about me going to the health center, but I am worried potentially about my kid having to change doctors. That wasn't something that I encountered. So I have to say that Lauren and her team are absolutely phenomenal, that when questions arise and employees email me, I'll forward it to Lauren, and they are on it usually within an hour. They work with that person. And one thing that I really appreciate about Lauren's team is that no matter what plan our folks are on, I never hear no come from Lauren or a member of her team. It is always a pathway towards a solution to the issue. Even if there is history between that employee and reaching out often because there are lots of concerns, it's not for lack of a response, which I really do appreciate.
So I'd like to add to yours that this open enrollment, we want to focus more on doing the math. The Healthy Advantage plan might not be the plan for you if you do the math. Yes, it has lower copays and lower max out of pocket, but if you add in the premium, maybe the Essentials plan is better for you. If you're already going to the health center, you're a health center patient, you're already used to them referring you out anyway, and like Dr. Shanoff said, if you have your child or your spouse covered, that premium is even cheaper than the other two plans, and it's an easy process because you're already a health center patient and they'll have those referrals on file. The OBGYN for women is just like the pediatrics for the children. It's no copay, it's just treated as a PCP. You don't need a referral for those. Same thing with mental health. So it's a very, very good plan. I know over the years we've heard about capacity at the health center, and I'm here to tell you they are tremendously improving capacity. We have a new medical director, Dr. Campbell, that started 2.5 months ago, and he's already made changes. He had one provider that told an employee that he was there for something else, that he couldn't do their yearly physical at the same time, and Dr. Campbell was like, why? You can do that all. So that eliminates 2 appointments for the person to have to come back later on, so that's improving our capacity. So all those things, like on the medical plan, we're constantly evaluating at the health center too to make sure that we are seeing as many patients as possible. And one of the proposals is to add the 2 new facilities at the 2 new transportation centers, plus a mobile unit as well, since that's pretty convenient for our employees.
Before we end, if you don't mind.
Can I just?
Yes, absolutely.
You said something right at the end, which I think maybe got lost in the shuffle.
So I've been wanting a mobile unit for years, and I finally got the go-ahead by our CFO to do some mobile units, so like the on-spot and the mammogram bus, for us to have one for the health center. So I got the go-ahead by Sarah for me to do the research this year on it, and there's a local vendor. It takes 22 months from the PO to build it out for us, so we're in the process of the layout with that local vendor so that we can have a mobile unit to go out to the schools from the health center. But the mobile unit won't be for your quickie-sickies. You still should do your televisits. This is to go see the diabetic, to go see you for your high blood pressure, your GI issues, so they don't have to drive to Simpson Road.
That's
They won't have to drive to the 2 transportation hubs as well.
Yeah, that's
We
great.
know that when we bring it on-site to either the main health center or to a mobile facility, it costs less to the school district.
Yeah,
So why not?
yeah.
Yes, every road in this county is under construction right now, so the convenience, the being at your school.
Yeah, I mean, adding the spaces at the 2 transportation hubs will make a difference. That will help, but it's not going to be the size of the health center, right? I mean, it's going to be essentially a satellite space of the health center. The idea behind the mobile health center is that in the same respect that everything else that we've made mobile, between the mammogram bus, on spot, and the vision bus now, we have seen that employees find value in those mobile units. The idea that now we're taking the health center on the road is pretty cool.
On the road.
And on the road to health. Yeah, on the road to a more healthy lifestyle, I think is fantastic, and definitely something that you will not see in other school districts. You won't see it in other large employers, large government entities. This is something that is new, and we're allowed to be this nimble with it because of the partnership that we have with Rosenshire. So.
We would be remiss if we didn't acknowledge one of the incredible members of our team, been with us about 1.5 years, 2 years. Mystery, would you stand up? She is a monster of data, and illustrations, and does
This is
just...
all mystery.
She is your account manager, and she just does an outstanding job.
She did that amazing benchmark for us, too.
Great.
Thank you, Mystery.
Thank you.
Thank you.
Any closing remarks or any final?
Any further questions by the team?
I have one. How are we ensuring, where it says on page 3 that we focus on quality as the active management, how are we ensuring that we're focusing on that quality and like getting the standpoint of people actually using the clinic?
When we talk, this slide about the quality is really about when the members are calling the nurse navigators for a referral or a
specialist.
recommendation for a specialist or even a primary care doctor, for any type of provider or facility. What is the quality of that place? And so there's a whole team behind the scenes that goes and does not use Google. They go and use all of the CMS data and all of those reporting that's available to them and provides them a report of who are the recommended providers and gives them all of the data on what's their grades as far as, outcomes, readmissions and all of those kind of things.
Numbers of
Procedures.
It's not quality of like how they feel their health care is going at the clinic, at the
So
SDOC
no,
clinic.
these are, we're talking about quality, well, quality for the clinic, we're always evaluating that too, but this is probably as far as scores out in the database world
General
of
population.
providers for, that are specialists in their care. So if someone says, I need to go see I need to go see an orthopedic for this, based on that member's issue, my 65-year-old with comorbidities is going to be very different than a 21-year-old that plays softball and hurt themselves, right? So what is the best provider for that member that has the best quality and outcomes for that condition?
But that isn't what you were really.
No.
But the health
So
center,
the
I just want the
Kenneth
people
question.
using the health center, like the SDOC Health Clinic, like how are we ensuring that the staff feel that they are getting the best care? And if there are issues, how is that fielded? Like, do they have to like email to complain, or there's a?
I mean, they do email, they call us to complain, because that's just the nature of our business. And we take care of those, like Dr. Shanoff said. But for the qualities in our contract with Rosen Care, we have performance guarantees on HEDIS measures. So those are national, right, Kenneth? Measures for diabetics, for blood pressure, cardiac issues. And then they have to meet those measures every year. And as long as they meet them, the quality is good. But they're also, Kenneth, constantly looking at quality.
Yeah, so you're absolutely correct. So we get service score ratings from every single visit, and you see those numbers are actually increasing. But also from the quality perspective, we're looking at HEDIS scores are, hey, did that provider take care of that diabetic appropriately? Did they get them the mammogram? Did they order the chest x-ray or a CT scan of the chest because they were a smoker? So all of those are quality metrics. On top of that, the service scores where we get those details. And, again, we're still teaching, educating, that we've had some where a teacher put in a 1, but then said, oh, Dr. Thatch and Dr. Hughes are all amazing. Well, they should have put in a 5 versus the 1. So we get those scores, we look at those, we look at how can we improve, and also looking at all the providers on their HEDIS measures and how they're treating the patients from what is the standard, but taking it up above and educating them about all the services that are offered throughout the district.
And Kenneth, what is the latest score?
Latest NPS was 87. So to give you a measure, in healthcare, most are around the 35 to 50, while this health center, and I think we have like 1,700 a month surveys that are being returned. So when you look at the end, that's a really good return. And we're up to 87. We were around the 82 to 84 for many years, and so it continues to improve over time.
So everybody that goes to the health center, they get a survey sent to them on their
Yes.
cell phone?
Yes.
And the amount of people returning those and completing them is
high.
what number?
About 1,700 a month.
I just did one.
Okay.
And it was 80,
82.
and that's net promoter score.
Now
So
it's
I think sometimes we hear 82 as maybe a C or a C plus or something like that. So I just want to be
It's a
sure we're.
B minus.
Okay, B, okay. So the net promoter score of a primary care physician that's owned by a hospital system, okay, not that has their own shingle, but owned by a hospital system, and most primary cares are owned by hospital systems, have a net promoter score of about a 3.
What did you say? A 3?
3.
3.
One digit 3?
What's that?
That's an
You
F.
said just a 3?
That's a 3.
That's wild.
Yeah.
That's an
Yeah.
F.
I mean, but don't you feel it sometimes when you go to that primary care doc that, you know, when you go up to the front desk
Yeah.
and not a lot of smiles and, you know, yeah.
So back to Mrs. Bronson's question, our complaints aren't about the care. It's usually about process. Something fell off in the process. And it's always a learning opportunity for us to fix about the process. I think in this entire time that we have Rosencare, there was one that came up on the quality, and once they looked into it, it was appropriate what they did. It was just the perspective of the person that it wasn't a good quality.
And then one more thing. The points that we have to get that are due by the end of July, I know I talk about this a lot. It's one of my favorite topics.
We know.
I know. But, so I just recently went and had some blood work done. Now, it came back it was okay, but I need to immediately make an appointment. And so I went in and immediately made an appointment. And they could not see me for a month, even though they recommended they needed to see me, because there's so many people trying to get these points. And so I have noticed, like, the summer becomes intense because people have to use their sick time to get to the clinic, because they have to take off of work, because, you know, everybody's a working mother and has other things going on. And so then that summertime, you cannot get in there even if you need an appointment desperately. So
Yes, our population waits till the summertime to get everything done because that's when they're off. But
Yeah,
one of the
but
things.
it makes sense.
It does. Same thing Christmas, same thing spring break, Thanksgiving, any break, that's when they get things done if they're not traveling somewhere else. One of your proposals to the union is to give half-day board leave for your yearly physical. So that should try and help
that
that.
wonderful idea in detail,
We've been working
please.
with the health center to do a yearly U review, so the month of your birthday, they text you and say, hey,
Yeah.
call us, you're due for your yearly physical. They're also working on some processes that before you leave for your yearly physical current, then they'll schedule the one for the next year on it. The points, even though it might seem overwhelming, once you log in, you'll probably see that you're probably at least have 80, 70 points. Most people don't realize that till they log in, because all your medical claims automatically get fed to the system, and then you just take the health risk assessment at 25 points and you have the 100 points. So it's fairly simple. Now, I will say, I am very lenient on the points. If somebody calls me and they have 95 points, I'm giving them 100 points. So
It's a bell curve.
it's just a bell curve. It's just something that we do because for some reason they just couldn't get that 5 points and there's no other way for them to achieve it. So we just give it to them.
Okay. I think I'm good.
Your plan is not perfect, but we strive for perfection.
And we're not perfect, but we strive to work together and do the best that we can and act as fiduciaries for you and your plan.
Thank you. All right, any other questions? With that, I think this work.
Thank you.
Colonoscopy.
This workshop has now ended.
20 points, 20 points for a colonoscopy, all right? I'll have my 100 points by the end of the month.